Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Good afternoon, everyone. It's Susan Coffin at Attitude Magazine, and we're very, very fortunate today to have Dr. Stephen Dickstein with us. Dr. Dickstein is with the Child Mind Institute in New York City, one of the preeminent organizations treating children with psychiatric disorders of all kinds. Dr. Dickstein is a child and adolescent psychiatrist, and he's got extensive experience diagnosing and treating a full range of psychiatric disorders. He was most recently director of the Child and Adolescent Psychiatric Inpatient Unit at Mount Sinai Medical Center here in New York. Dr. Dickstein's topic today will be treating ADHD across the life cycle. He has an interesting perspective in that he works with both therapeutic behavior therapy, psychotherapy, as well as medication, can address the combinations of treatments that are available across the life cycle from preschoolers all the way up through people in their 50s and 60s. Be aware that, as always, Dr. Dickstein is not offering medical advice. He's giving us general information about treating ADHD and other psychiatric disorders. So with that, let me turn it over to Dr. Dickstein, and with our thanks for spending time with us today.
No, thank you very much for having me. It's really an amazing pleasure to be able to connect with so many people this way. People obviously have interesting questions and real experiences, and I hope it can be helpful. I mean, my main job is to try and help kids and families do better. That's what I do for a living. I'm trained as a pediatrician, psychiatrist, and child psychiatrist, and so I feel lucky that I can work with families and work with adults and help them do better as best I can. But it is complicated. And as you said, this is a chance for us to talk and ask questions and answer questions and provide information. However, there is no substitute for being able to talk with your doctor, tell them about what you're experiencing so that they can work with you to figure out a way to make things better in a treatment plan that makes sense for you and for your child, given all the different factors, because things are complicated. Just to start out with, we're talking about treating ADHD across the life cycle, and I guess we're going to talk about what is ADHD, which you guys already know, and also what's a life cycle. So basically the idea is that people are born and they get older and they develop through different stages. So having children means you get to watch them grow from being babies to toddlers to, school-age kids, preschool-age kids, and then eventually into high school, college, and then they become adults themselves. And then the other end of development is also you go through adult life. You raise your kids as you get older, which my parents are in that stage now, getting older. And on the other end, end of life is different. So there's a whole life cycle of different parts of life. Each have their own challenges, but also each has their own things you have to, work on to solve for everybody. And then if you factor in, how does ADHD relate to that, that becomes the job of really a child psychiatrist, a child and adolescent psychiatrist, who tries to factor in, well, what do we know about ADHD? And what do we know about normal development to really make a good treatment decision plan at every stage for every kid we're meeting? Given the fact that, right now we still don't have an MRI, an X-ray, a brain imaging test that can really diagnose and measure it. We can't measure ADHD via a biological marker, which is different from other parts of medicine. Other parts of medicine, if my blood sugar is too high, I can get a blood test, I can check my blood sugar, I can check my hemoglobin A1C, I can get markers of these things. In psychiatry, we're still not there yet. We hope to be there soon, and we've got people here where I work at Child Mind Institute who are really trying to push the science forward, but in general, again, these are just, they're not ready for prime time as far as helping me treat patients clinically, so I've got to use my brain and my understanding and my knowledge to treat their brain and how to help them. So, again, if you think about really young children, the younger they are, the more appropriate it is that they have a short attention span and are kind of impulsive. That, if you think about a toddler, they run around, they grab things, you have to watch them all the time because their brains haven't developed impulse control, they haven't developed their brakes, and their gas is always, they're always interested in things, they're checking things out. And again, the younger you are, the harder it is to sort of say, is there a difference or not a difference? Because whenever you're working as a physician, you're trying to factor in, well, there's normal development, so kids at a young age act a certain way, typically, within a range, and how do you factor that in? So the younger they are, the harder it is to tell because there's not that much difference. I mean, for some kids, though, that are really having a difficult time, there's tremendous difference. However, there's lots of different factors that can get in the way of a child paying attention or controlling their impulses, and ADHD is just one of those things. So as a doctor, I really try to think carefully about what am I seeing, who am I working with, what are the different possibilities, and then how to understand it. Because ADHD is a diagnosis, it's a clinical syndrome diagnosis. There's not a blood test. There's no measurement other than getting a good history, finding out how the child is doing, in all areas of their life. So how are they doing at home, how are they doing with peers, and how are they doing in whatever school setting. So the other part is also that because development happens over time, different treatments may be more or less effective at different ages because the brain's developing, the person's developing. There's a lot of factors. So really, I think tailoring the intervention after you make a diagnosis of ADHD, which is not an easy thing, but you can make a diagnosis of ADHD carefully. But then you've got to tailor the treatment to the most effective treatment for that age. And we'll talk about what the data is. Certainly, when the best data we have is how to treat school age kids, so kindergarten through high school. We've got really good data about how they respond to treatment for ADHD, what works, what doesn't. We've got decent data for adolescents. We've got some better data than we used to have for preschoolers. And the adult data, it's interesting. It's a relatively new field in the last, I think, decade, 15 years about looking at adult ADHD. And so, again, the level of evidence and the understanding of things is still developing in sort of the range, in the preschool range, the young children, and also the older people. That's an area that needs a lot more study. So, but again, there are lots of good research studies out there, and how do you understand them and how do you make choices is really an important thing. So when you think about, I like ADDers, people with ADD, because, that's just one part of their life. But as they transition from the idea of being a child to being an adult, so really being dependent on their parents and adults in their lives to structure them, getting to the point where they're actually independent, they're making their own choices. Again, nobody ever does it alone. We always have other people helping us, but the idea that you're given primary responsibility for your life as an adult role, as opposed to being an adolescent or child where really the adults in your life are still in charge. So how do you make that dance happen? It doesn't happen all of a sudden. So just because you turn 18 doesn't automatically give you an adult license. It does in some respects, but lots of things have to happen before you turn 18. And as you get after 18, there's a whole transition. Adolescence, especially in this world now, can be very postponed. There are many people in their 20s who are still, in graduate school or whatever. They're dependent on their families for lots of things, and that's okay. But the question is, who's ultimately responsible, and how do you build those skills so that you can make sure that the child to make sure that the child is prepared to take over that role once they become an adult. So again, the issue is, how do you tell kids about what is ADHD? So, it's a complicated thing to describe even for adults. But whatever you want to tell them, you make sure you need to tell it's not just a one-time conversation, it's an ongoing conversation. And you want to let them know they have this, but it's not their whole persona. And also that, medications will help relieve symptoms of attention and focus. But it doesn't necessarily make you smarter or not smart. Intelligence is a separate thing from attention. Certainly you need both to do learning. So you need your attention and you need the capacity to learn, but they're different in that you want to make sure the kids know exactly what the medication is doing or what their diagnosis means and what it doesn't mean. So for example, if a child wears glasses, and again, ADHD is not exactly like glasses, but there's some similarities because glasses help focus things that aren't focused. If a child wears glasses, they could say, I'm just a 4 eyes, or something like that, which we don't say anymore, which sounds so outdated it's even ridiculous. But if you help them know, the glasses help your eyes focus, so you can see things, but how you use your eyes, you've got a creative ability, you've got talent, you've got an artistic eye, you've got the reading you do, all those things. The glasses don't teach you how to read. They don't teach you to be an artist. They just allow your eyes to see what's there so then you can use your brain. And again, that's that interesting idea of how do you give a message that makes sense to kids when it's hard to explain these things. But at every level, they need to know different things. So for example, if you've got a 6-year-old, I wouldn't necessarily go into a long description about the neurobiology of what we know about ADHD. It'll be confusing, it'll be strange, they won't know what you're talking about. But there are ways to tell a 6-year-old, look, interesting enough, your body, your brain is built a certain way. You're a very excited person. You're always on the go, and it sometimes means you're doing things that other kids aren't doing or that the teacher doesn't want you to do, and it's not because you're a bad kid. It's actually because sometimes your brain has a hard time switching gears. So this medicine, if you choose to talk about it as a medicine or whatever you're talking, we're going to help you figure out how to do that so you can let you be who you want to be. Because if you don't tell them that, they're going to get confused. But also, if you don't treat it for a young kid, they're always in trouble anyway. So that we definitely don't want that to happen. That's not healthy to always be told you're being bad or you're wrong, when the truth is you didn't hear the direction, or your brakes didn't work to stop you from doing the thing you were doing. Next, so that's again the idea of how do you let kids know. But again, six-year-olds need to know one set of issues. Teenagers will have other questions. College students will have other questions, and adults have other questions, and it's an ongoing discussion. That's why you really want to send the message early on and say, this is one thing we're dealing with. Just like if you had a child with asthma. A child with asthma needs to know that for their lungs to work properly and they need to take their medication, they've got to be careful. But it doesn't mean they can't be an athlete. So that's where these kind of discussions, how do you make the right language, that's, again, hopefully that's the kind of thing that this organization, that these discussions will help us creatively find ways to talk to kids at different levels to explain what we know and also some things we don't know, to help them feel good about themselves and be able to eventually handle themselves so they have a good relationship with themselves, they treat themselves with respect, and they also take care of themselves. So again, how to manage the issue responsibly. Adolescents themselves, by and large, are non-compliant. The truth is actually everybody's non-compliant. Adolescents are especially non-compliant for a couple of reasons. One is that adolescents want to see themselves as invulnerable. Therefore, they don't want to bother with any help for anything. And that's a healthy thing because they want to assert their independence. The other thing is also adolescents are really busy. They've got a social life. They've got things to do. They've got things going on. And it's actually hard for everybody to remember to take their medication. So therefore, adolescents especially, they're so busy. There's so many things going on. That gets in the way. It's easy to forget. The other thing is that fine balance between, yes, your adolescent is growing up, and so they are physically capable of taking the pill bottle out of the cabinet, opening the pill bottle, and swallowing the pill. However, it may be that for adolescents, they also need to problem solve and structure that with a parent, but they figure out, well, how do we do this together? How do we make sure I take it? Finding that definite balance between the parent doesn't want to nag, because that makes the kid want to rebel, but also that the kid themselves may have some trouble remembering things, and they suffer for it if they don't take their medication, if it's working. So again, it's finding that delicate balance, but I think the best way to deal with it is to talk about it honestly at a time that's not an emergency. So I wouldn't talk about it in the morning when it's time to take the medication. These are discussions you have in the quiet times when there's no emergency, where you think about how do we help you, my child, become the adult person and take responsibility, because I don't like to nag, and you don't want to be nagged at, but these are all important things we want to take care of. So that's that transition period again. So here's a chance to ask questions.
We have some wonderful questions, Dr. Dickstein. To the point of through the life cycle, these questions range from ones about 3-year-olds to all the way up to someone who's 66. So I think that's sort of perfect for your the topic that you presented. Shall I start then with a preschooler, and we'll try to sort of go through the life cycle with these questions and kind of get at some of the issues as how treatment changes over time.
That's great.
One of the first questions is from someone who says that when do you consider it a legitimate reason to start ADHD medication to a preschooler, 3 or 4 years old? In this family, they don't feel quite ready to medicate a 3-year-old who's been diagnosed with ADHD by a child psychiatrist, but they're very concerned about his safety, impulsivity, tantrums, and negative self-image that he's developing. So they're really struggling with that issue of child being yelled at, not performing well, versus medication. Similarly, and I'll throw another question in, which is similar. Someone who's 5-year-old being treated with ADHD medication, and she's saying, it's working well, but she's looking at his whole life ahead and wondering, is this really going to be safe for him to be on these medications for what may be, 40 years or whatever. So what's your thought on the diagnosis and treatment of 3, 4, and 5-year-olds?
Wow, that's actually
That's a lot of questions. I know.
that's a lot of stuff packed there. But that's okay. But those are the real questions. This is what parents ask me when they come in, and I think, yeah. So let's start with the 3-year-old, because I think that is the most important question to think about and talk about. Because so if you look at the data about actually the 3 to 5-year-olds, so there's a really the best study that was done is called the PAT study. It's the Preschool ADHD Treatment Study. It was done a couple years ago. The data has come out already, and it's been out for a while, and they're going to follow up on the data. But basically, it was sponsored by the National Institute of Mental Health, a multi-site study. And they were actually asking this exact question, like, how do we understand the best sequence treatment for preschoolers, age 3 to 5, so with ADHD? So what they did was they, again, the study is probably better explained somewhere else, but basically they, first of all, they tried to figure out, does a child have ADHD or not? So the same criteria for ADHD apply at all ages. The number of symptoms of impulsivity, hyperactivity, distractibility, different from your age-related peers, and causing functional impairment, which I think that's the biggest thing. That, again, if a child is, bouncy, exuberant, hyperactive, has all of the physiology of ADHD, but it's not causing them trouble, then that's fine. They don't need treatment necessarily. Again, necessarily, although it depends on what that means. So the first question is a diagnosis, and again, I think that's great they saw a child psychiatrist, because really a child psychiatrist, I think, is one of the best people trained to look at these things carefully. So ADHD is a diagnosis of exclusion, so that if you have a child who's not listening, not paying attention, hyperactive, you want to go through a lot of other things to make sure they're not there. You want to make sure that you've done a careful assessment, because kids that are essentially being oppositional or off the same page, sometimes kids with hearing problems have that issue. Sometimes kids with language problems have that issue. Sometimes kids who are very anxious have that issue. Sometimes kids who are on the autism spectrum have that issue. There's a lot of different things, especially at age 3, that can get in the way of paying attention to directions, following directions, getting along. So a child psychiatrist's job is to really be very careful and systematic about getting all the data, meeting the child, talking with people in the child's life, understanding them in a way, and the good thing is there are some very established rating scales you can use that actually statistically seem to help identify the issues and try to separate them out. But at the end of the day, it's really a doctor and a family making a decision of, does this diagnosis exist or not? So the kids in the PAT study, first they went through a rigorous diagnostic evaluation, a standardized one. And then what they did was, I believe, they actually enrolled all the kids that seemed to have ADHD. They gave them 4 weeks of behavioral therapy, sort of parent-child, parent training, parent coaching, modules like that. But not just like a handbook, like real, working with real people for, I think, about a month. It may have been longer. And they only took the kids in the study that actually didn't get better. So some kids at that age, when you do behavioral therapy, the behavior gets better. Now, whether they still have ADHD or not is a separate question, but it's all, in some ways, preschool ADHD is all about compliance and getting along with the group. That you have to control your impulses enough to play with other kids in a preschool setting or something like that. So that's it's the main goal, I think, in preschoolers is really about usually dealing with impulsivity and aggression, usually. So behavioral therapy for some kids can actually help with impulsivity, and in some ways it actually doesn't necessarily change the kid, it changes how the adults act around the kid. So for example, if your child has a hard time hearing you, yes, one can yell at them, but that makes them upset when they hear you yelling because they didn't hear the first time. So there's ways of basically, parent-child interaction therapy is one that we do here at the Child Mind Institute, which is using a one-way mirror coaching system. There's another system, the Rex Forehand, Parenting the Strong-Willed Child. There's Incredible Years. There's a number of different programs that are out there that really are geared to helping parents work with young kids in a positive, effective way. So I guess for any 3-year-old, I would definitely make sure that there's been a good dose of good parent training or adult training, basically parent-child behavioral therapy with a good person. There's good evidence to say that that's helpful no matter what. And I definitely would probably do that first for a 3-year-old. I think that 3 is really young. And then the question is, once you see the response to that, so if you monitor with the person. It's usually a psychologist or social work therapist, usually a psychologist at this level of kind of intervention, who specializes in young kids, because preschool kids are different than older kids. Not everybody is well trained to work with preschoolers, or likes that for that matter. So once you have that given a trial, then I think the question is considering medication. So getting back to the PAT study, they had treatment arms. One of them was placebo. One of them was methylphenidate. And as they found out, that yes, preschoolers do respond to methylphenidate, which is the same as, Ritalin. But the incidence of side effects is a little bit higher in preschoolers than it is in older kids. So a little more, instead of 1 out of 25, 1 out of 30 kids getting sort of irritable or cranky, it's a little more than that. Sensitivity to appetite suppression, a little more common. But for many kids, for most kids, it's safe and effective, and the medication works. So
if I remember, just to jump in the PAT study, which is really fascinating, I think didn't they recommend as a result just lower doses because of the sensitivity of preschoolers?
I think that's where we don't have, as far as dosage choices, the motto I always learned as a child psychiatrist is start low and go slow.
Right.
And I think that, so little tiny doses may be effective because, again, they're at a different developmental stage, their bodies are differently sized, and even with all psychiatric medication, but especially stimulants, we don't really have a good algorithm of you weigh this much, therefore you must take this much. The weight-based data is not good because there's so much variability, because kids, yes, they are smaller than adults, but actually their kidneys work really well, their livers work really well, so sometimes they get rid of medication quicker than adults. So the only way to do it is really do one step at a time. But the preschool data would say that actually the doses should be lower than for older kids.
Which makes sense, I guess. Yeah,
and I think that it makes sense. But again, until you do the studies, the problem is you don't know.
Right.
I think it was a great study to do. The 5-year-old, it's different because actually there's a lot of. We have a 5-year-old daughter at home, so I know what a 5-year-old looks like. I think at least one of them. And, it's amazing the development that happens between age 3 and 5. You go from age 3 where you're sort of doing some parallel play, and you're kind of getting your feet wet and talking with other kids, to now I can actually have real conversations with my daughter, and that she tells me things that are totally spot on. I'm embarrassed to say, wow, you're totally right. And it's not embarrassing. It's actually wonderful to hear her say that. But there's a lot of 3, 4, and 5 are all different ages. You wouldn't necessarily put a 3-year-old and a 5-year-old and expect them to play easily together. So I think that's where it comes down to the 5-year-old is a different kind of thing. But I think that so let's unpack it a little bit. So the real question that the person with the 5-year-old was asking is not so much a question of is this working or not, because they see it's working and it's helping them. And that's, again, if it's not helping, you don't do it anymore. But the only way to find out if it's helping is you have to try. So they had the courage to say, look, we realize there's an issue here. We want to talk to a doctor. We want to get good treatment. Let's give it a try. Now the question is long-term effects of being on these medications. I think it's an excellent question. And I don't know if you ever saw on our website the video from Rochelle Klein. Did you see that one at all?
No, I haven't seen that.
So actually interesting. So Rochelle Klein is a psychologist, a very prominent psychologist actually at NYU. And she has been in charge of the New York study, which has been, can you hear me okay?
Yes, absolutely.
Okay, sorry, my screen went blank, but it just got sleepy. So she's been in charge of the New York study, which is a longitudinal study, started in the 1970s, I believe, that took 7-year-olds at the time that had ADHD. And they've been following up ever since. So these people are now in their 40s, I think, and they're still being followed every couple of years with assessments, and now they've added brain imaging and all these kind of things and life questionnaires and things like that. And I think that her study is one of only 1 or 2 that's really going to answer these questions.
Right.
Because really, we know that there's, and again, the video on our website is really nice. You sort of Google her, or Google, whatever, Rochelle Klein, and Child Mind Institute, and then she's got a 1-minute video where she talks about this issue. So basically, you're always balancing the risks of not treating with the risks of treating. And the risks of not treating are actually huge. We have tremendous data on what's the natural life course of a kid with ADHD who grows up to be an adult with ADHD, and the different levels of stress they go through, whether it's school difficulties, relationship difficulties, increased risk of car accidents, increased risk of substance abuse. All these different risks are there. Those are well established.
That's really an important point that we don't often talk about, the risks of of not treating. I mean,
Right.
whatever the treatment may be, but right.
Yeah, and again, I think,
Talk about it enough. Yeah.
I think it's that's another hard thing is to measure, because again, how do you really, what you really want to know, if you're really going to answer this question for your child, you would need a time machine. You would actually need to put them on medication and get in a time machine, go 40 years in the future, 30 years in the future, and then find out how they're doing. And it's an impossible thing to do. But it's also impossible to do this study, because what you really want to do from a research standpoint, which is a completely impossible study from both ethical and financial reasons, you'd want to take a group of kids that have the exact same ADHD in the exact same way and give one group placebo for 20 years and give the other group stimulant for 20 years. But you can't do it because it's just not ethical to do it. It's also impossible, but we know that these treatments can work effectively for some kids, and therefore you just can't do the study.
Right.
But the risk of not treating, I think it's hard to say, especially because I work with families that are, I've got a 5-year-old, so I'm almost 40. And so I grew up at a time where we didn't know as much, we didn't hear it, we knew a lot about ADHD. And actually, ADHD has been around forever. Stimulant medications have been around in use since the 1940s, 1930s. They're old medications. However, the knowledge about what ADHD is and what it isn't, what stimulant medications will do and what they don't do, that knowledge has actually been really more prominently talked about in the last, I'd say, 10, 15 years. And so when parents think about their own childhood, and again, many parents with kids with ADHD, there's a lot of genetics to it, so they may have also had ADHD more often than not. And they will say to themselves, look, I was fine, I was okay, I got through it, they didn't do this. So, and again, and all those things are true. They are fine, and they didn't get on medication. And again, the question is, what would they have been like if they had? Who knows?
Right.
But if these ideas, these issues about medication have meaning, and there's strong feelings with them. And then I think that we're always balancing as a physician. My job is to really, my first and foremost job is to do no harm. But sometimes if I am not treating something that can be treated, that actually is doing harm.
Right.
And then, but again,
on this question of choosing medication, which is, I'm sure is just extremely difficult for parents.
Sure.
There are a number of questions here about alternatives to medication. I want to know your point of view on nutritional treatment, the impact of nutrition, of homeopathic remedies, or of non-stimulant medication, specifically, again, in school, it's moving up to school-age children now, primarily.
I think these are the questions that parents ask. Is there anything I can do instead of giving my child medication?
Right.
That'll be effective and helpful. So actually, sorry, I realized as I was going on, because it's the point of Rochelle Klein's statement, though, aside from the risk of not treating, is actually there's been no data whatsoever that there's long-term impact or deficits or problems.
Well, that's important. Wow.
Yeah. I buried the lead there. I didn't put the important part of it. Because actually, and again, these medications, again, if you think about it, they've been around since the 1930s. There are millions of prescriptions out there. The way you find out if a medication has problems that are even in small groups of people, you get the aftermarket data, just like when you have other medications that are on the market and then they find out, oh my God, it causes this in 1 out of 1,000 people. So the aftermarket data seems, as from my reading of it, amazingly good, that there is not been any signal or change or brain effect or anything as far as I can tell. And also when I talk to parents is, if you think about it, like these medications are very temporary medications for good or bad, so that when I have a child take a stimulant, it works when it works, and then when it goes away, it's not there anymore. If they don't take it the next day, the kid is exactly like they were before. There's no carryover effect as far as I've ever seen. Therefore, that's good and bad. So the bad part is you're just treating symptoms, and you have to keep taking the medication every day. The good part is I do think that's actually pretty good evidence that there is no brain change that's happening, no significant, long-term brain change, because if it was, there would be some carryover effect. Again, but that's the part that I think it's hard to measure those things, but just in broad strokes, there hasn't been any signal of aftermarket difficulty despite millions of prescriptions over decades. And because the stimulant seems to be a short-acting treatment, my read of that data would be that it may likely not be making permanent changes in the brain. It's really just adjusting the circuitry, adjusting the chemicals in that moment. But again, that's where I'll defer to my neuroscience colleagues to answer that question.
To that point, on the one side effect, there's a couple of questions about this, that people do feel or have the impression that there's statistical evidence for is appetite suppression. Is that here's someone who's 8-year-old who's
absolutely.
not
Yeah, so the
gained
most,
weight.
sorry, what they
Go ahead.
failed to gain weight.
Right. Having the stimulant.
100%. So actually, if you look at the data, the most common side effects, the most common side effect is appetite suppression. And the question is, from a global standpoint, from as a pediatrician, as a doctor, if they don't eat lunch, I'm okay with that as long as they eat enough for dinner and they grow. So that's where I think that different kids are more sensitive to than others. So, for example, some kids I work with, literally they can barely eat lunch when the medication's in their system, but they end up having 2 dinners. And they have one dinner when they come home and then another dinner later on when they're still hungry. And that as long as the data would say that as long as I believe the total number of calories in 24 hours is okay, growth will happen. Growth will be fine. The data about the long-term studies about growth effects, the stimulants, it's actually mixed. I think some studies will show that there is no effect. Some studies show like a minimal effect. My understanding about the reading of it is, well, first of all, just with any kid, you have to monitor the growth. So you actually literally have to follow a growth chart with a kid on a stimulant very carefully. So instead of going once a year to the pediatrician to see how your growth chart is, you want to go, every month or so initially, or every couple of months, and then deal with it. So if the kid is not eating and they seem to be either, more common, it's just they're not gaining weight appropriately as opposed to actually losing weight. But then you actually want to strategize to say, number one is there any way to introduce more calories? Either, high intensity calories for breakfast, like, again, I don't mind a kid eating ice cream if that's what they need. Or for some kids, actually, the risk in that child of appetite suppression is not worth the benefit. So you have to think about other medications, whether it's, other stimulants, different types, short-acting versus long-acting.
Right.
Stimulants. And there's a lot of different ways to think about it. But absolutely, I think the most important part is that, yes, these medications can have side effects. And the only way to deal with it is to have a good relationship with your prescribing doctor who's going to be there with you to make sure it works out okay and adjust as you go along because, as anybody knows who takes these medications or has seen their child, when it works, it's amazing. It's literally life-changing. But you want to make sure that the benefits 100% outweigh the risks. And if there are risks that you need to deal with, you deal with them.
Yeah, I think that what I'm hearing you say is I think what we've often said at Attitude, which is sometimes we hear people say, well, my child isn't growing, but that's a price I have to pay for dealing with ADHD. And I think the recommendations that we've heard support what you're saying, which is no, you need to adjust something. You don't accept those kinds of side effects. You make adjustments either in the medication or the nutrition or something. But
absolutely, you work together with your primary care doctor, with your psychiatrist, with whoever you need to work with, because again, the tricky part is so some parents will have to say my child may be skinny, but that's the price I'm paying for ADHD. Yes, that's true. Some kids may be skinnier than others, and in some families, parents have different perceptions about what an okay body habit is. In my family, food is love. So therefore, a skinny child is not being loved. And so, but again, I think that just on a serious note is that it's an ongoing conversation, and that if a parent the decision to medicate is a complicated decision, but it actually is not. It's a decision every day you give the pill. That literally, when I work with a family, so a family comes to me because they've been referred to me because things they've tried haven't worked. So they've been recommended to see someone to consider medication for ADHD or to find out, do I have ADHD, and then to consider medication. Because medication works for ADHD. And psychotherapy doesn't actually work for the core symptoms of inattention and hyperactivity. Because you need your attention to be aware of how to change things, and therefore it's a catch-22. And the data would support that. But again, I tell parents, look, the first question is, do you have ADHD or not? That's a diagnostic question. We sit, we talk, we understand it. Once we decide if your child has ADHD or not, then we decide what to do about it. And so we talk about, is medication right? We talk about all the pros and cons of it, risks and benefits, and then ultimately we have to decide to try it, because until you try it, you don't know. And then the next decision point is actually, does it work or not? So the decision to try is different from the decision to evaluate, is it working or not? Are the benefits outweighing the side effects? Are there any side effects? Because many kids actually, the majority of kids I treat have almost zero side effects. Once they get used to it, it's very, very safe. very, very, not only is it safe, it's always safe, but it's very, very, it's non-issue. So then, as you're working to figure out, does it work, is it the right dose, then you're actually deciding how long does my child stay on this medication? Because I never, ever have ever asked a family to agree to lifelong medication at any age. It's always a choice. But it's an ongoing discussion. I think that really, for kids who have ADHD, usually it's the school-age kids we have the most concerns about. We don't want to mess up their school year. Therefore, if we're going to try a trial off of medication at some point, you want to pick a time that's a non-critical time. You want to pick a time that works for the family schedule. And each year you may want to decide, do I stay on the medication or not? It's a discussion, certainly. And a parent should never feel like, oh my God, once I go down this road, I'm stuck. That's not a safe feeling. It's not an accurate feeling, and it's an ongoing discussion with the doctor, just like anything else.
Do you feel that, do you have any point of view on stimulant versus non-stimulant medication? There are a number of questions here about, one person who is actually a doctor says he's tried using non-stimulants and had little success, and others are asking, whether there is a non-stimulant option. And along with that question comes, and maybe they're not related, but some people seem to think they are, there's a question of whether there are different medications for inattentive ADHD versus hyperactivity.
Okay. Again, as always, a lot of good things. So I think actually I want to get back to your complementary question, because I think actually the complementary medicine question is right in there very nicely. So I guess one question is, why do these medications work? Because if we could figure out why do they work, then we would understand who's it going to work for, who's it not going to work for, and what else could work instead. So there's actually a lot of data about the neurobiology of ADHD, but it's still an open question of exactly what causes ADHD, what the neurobiology of it is, and what the medications actually do. There's some open questions there. I mean, they're interesting questions. The data would suggest that a big part of ADHD seems to relate to different circuits in the brain related to like prefrontal cortex, basal ganglia, cerebellum, and a whole network that's basically the job is to help you stay on task when things are interesting and to control your impulses. And dopamine is a chemical that seems to be very, very, very involved in all those processes. And the stimulant medications are involved in increasing the amount of dopamine released from the neurons. So these are dopaminergic medications, dopamine active medications. And dopamine is a chemical, a neurotransmitter in the brain that the brain produces. And the stimulants, amphetamines, methylphenidate, all the different kinds, Adderall, Vyvanse, Concerta, name your stimulant, they all do something to help release more dopamine. Whether they block the reuptake of the dopamine so that more is in the synapse, or whether they actually help the cell actually push more dopamine out in the moment, that's, I think that's a physiologic question that I'll defer to my neuroscience colleagues. So the issue is also a dose effect. So if you take the right dose of a stimulant, it can help you focus and pay attention, maintain alertness. If you take way too much of a stimulant, it actually does the opposite. It actually makes you overwhelmed and confused and agitated. Very much like, if you think about the common stimulant used in today's culture is coffee. I drink coffee in the morning. Now, just to be clear about the complementary stuff, there's actually been some studies, does coffee treat ADHD as effectively as the stimulants do? And the answer is no. The caffeine is not as powerful, it doesn't work the same way, although they're both stimulants. So, but it's a dose effect. So taking 1 cup of coffee provides alertness and clarity in my mind. But taking 50 cups of coffee would not make me feel good at all. So that's why it's a dopamine dose effect. And related to dopamine also is this question of hyper-focusing. You talk about that a lot. So, like a parent will bring a child to see me, and they say, you know what, they're amazing. They love reading. They can lock into reading, but the school says they can't focus and pay attention. What's up with that? And I don't know exactly. This question of hyper-focusing versus the ability to override the difficulty focusing is interesting. I mean, I do wonder that if you think about when you're enjoying something, when you're really passionate about something, what is that doing to your brain? I mean, actually, there's some data to say you're releasing more dopamine. That when you're really enjoying something, when you're really stimulated by something, when you're feeling good about something, that's a dopamine process. And kids with ADHD,
does that suggest then that for supplements and complementary treatments to be effective, they have to also have a dopamine effect?
It's a really good question. So the issue about stimulants is there's not enough data. That there's a lot of people out there that will give you anecdotal data, say this works or that works. And the only way to tell if something really works is actually have a randomized control trial where you have a placebo. Otherwise, you can imagine anything. I mean, the truth is actually for ADHD, placebo effects are very low. That compared with other psychiatric medications, stimulant placebos don't really work. I mean, you can't convince yourself to focus more because there's not a lot of, I don't think there's a lot of psychological control over your ability to focus. It's like if you're tired and someone tells you wake up. It's hard to wake yourself up. You're not aware of it. It's not in your awareness. It's not in your control. So I guess the real answer for any complementary medicine thing is, number one is there been any study that actually compared it to a placebo or compared it to a standard treatment? And the truth is that I don't think there are any studies out there that look at it. I mean, there's some studies I think that tried to look at fish oil. I don't think the data was very great. I don't think the effect was very high for ADHD. For other things, for heart disease, yeah, fish oil is great. For macular degeneration, I think fish oil is a very important thing. For lots of things, I mean, fish oil is a good thing, but as far as does it work for ADHD or not? But I think really the question is there's a lot of lacking data.
Okay. And in terms of the non-stimulant medications, we have a couple of people here whose children are responding with aggression while on stimulants, and they've been advised to add a non-stimulant, and they're hesitant to do so.
Yep. So the non-stimulants are basically, in general, they work on norepinephrine. So norepinephrine is another neurotransmitter in the brain, and also it's the common name for norepinephrine is adrenaline. Adrenaline, noradrenaline, they're different chemicals than dopamine. They're interrelated. And the non-stimulants are things like guanfacine alpha-2 agonists, so that's a brand name of guanfacine is 10x or Intuitive. Clonidine, again, also an alpha-2 agonist, so again, works on in the brain centrally on norepinephrine, adrenaline in loose terms, not dopamine, or not necessarily dopamine. And the data would say that they're not as potent as far as helping you focus and pay attention. Although, again, that's my read of the data. I think that's, again, that there's not, they're very safe medications. Have been around a long time. But they do help more, it seems, with the impulsivity and hyperactivity piece. So oftentimes you get a kid who has been, okay on a stimulant, but they're getting aggressive or they're still impulsive, and so you might use the combination of a stimulant plus a non-stimulant. And then there's also some kids that don't tolerate the stimulant. So you're describing that the child got irritable and aggressive on a stimulant, and actually that that happens, and probably it's not common, but it's not so rare. So it's like 1 out of 30 kids, 1 out of 25 kids, when they take a stimulant, they may be irritable. And in that case, usually I try to really understand, is this the right medication for them or not? Because I don't want to cause side effects from medication if I don't have to, or I want to think about alternatives. So, but I think, but
that
also,
makes sense.
Yeah, but I think so you have to unpack it. So again, I think that non-stimulants can work well. The data would say they're not as potent. The other, if you think about non-stimulants also, you have medications like atomoxetine, which is the brand name is Strattera, which is a norepinephrine reuptake inhibitor, which is in some ways chemically similar to the older tricyclic antidepressants, which actually used to be used for ADHD, things like nortriptyline. And I've got colleagues, again, I haven't, in this current stage, we don't usually use them so much, but those were well used. And the nice thing about the non-stimulants, though, is usually the only benefit of the non-stimulants is they don't cause appetite suppression. They don't tend to interfere with sleep issues. And sometimes they seem to be effective maybe for 24 hours, maybe, if you dose them the right way. So I think that's the advantage of a non-stimulant.
That's interesting. Right.
So again, it's sort of like sometimes the combination of a stimulant and non-stimulant, because the stimulant itself is only lasting 8 to 12 hours. So the non-stimulant piece may be helping to cover part of the time when the stimulant is no longer there. But that's, again, the only way to figure it out is really to do step-by-step with your doctor, figure out what are the options, and then measure the intervention that you do in a careful way, which is why I think that, I think you're being very sensitive. You don't want to put out there me giving advice to people who I don't know, because you're right, that I can't fully treat anybody who I don't know and spend time with and monitor in an ongoing way. But I think that whenever you make an intervention, you want to know the pros and cons, the risks and benefits, and then have a good plan for monitoring to decide if it's helpful or not helpful for your child.
Okay. We want to move quickly, with our remaining time, into some of the later life cycle. I really want to get to some of these adult questions. But quickly, for college students, many parents, have some real concerns about their children staying engaged in college, not dropping out, not sleeping all the time, not taking the medication. There's a lot of concern that we encounter, and that are some specific questions on this webinar related to that life stage, the college, the transition to college at the college student age.
So I think preparation is the key. So discussions about how to help your kid make the transition from high school to college, especially if your child has, ADHD or any special needs for that matter, that discussion has to happen, 3 years ahead of time. It has to be not only discussed, not in a scary way, you don't want to alarm the child, but you actually want to prepare for it. So you actually want to discuss it with the child, say, hey, what kind of college do you think is going to be right for you? Do you want to go to college? What are you worried about? How do we manage it? You want to get as much information about, whatever college you're thinking about going to, what the mental health supports are. And you want to work with your child's doctor to sort of, think about how do we prepare, like how do we train them up for being more independent so that it's not like you all of a sudden go from being a child in your parents' home to being in a dorm room on your own completely with no preparation for that. That wouldn't be fair. And again, I would be worried about that, especially if a kid, college provides a lot of temptations. It just does. The schedule is different. The responsibilities of how you manage things are different. The supervision and monitoring is completely different. And it's all good. It's important because it's a necessary stage, but also, you're not really giving up your total parental rights. So I think it's definitely communication and planning are the keys. I think the parent probably, one way to do it is actually, a year or two before you go to college, if you have that luxury, or at any point, a parent should write down their whole list of worries, their whole list of concerns, things they anticipate would be problems, and then present that list of concerns and worries to their child and their child's doctor. And that way it invites a conversation where everybody can brainstorm together. And the most important part about the process, though, is you don't have to sign in stone what the plan is going to be. You say, we're going to try this first. This is our plan. And we're going to check to see. We're going to monitor. The great thing is colleges provide outcome measures. They provide grades. So how's your grades in your semester? You also can find out how's the child's, social life, everything else going on. There's lots of ways to keep track and involve the kid, the parent, the doctor, and the school in that process. And that becomes a very exciting way of making a transition as opposed to a scary thing. But it is anxiety provoking. So I think preparation is the key.
Okay, great. The couple of questions here about college students or kids who have come home from college, dropped out of college, and just seem unmotivated. And that's certainly a common issue, whether a kid has ADHD or not. But it seems to be pretty common among our families.
How do I help my post-college kid or my dropout?
Yeah, who's kind of seems inert, doesn't really know what to do, spends a lot of time online, doesn't really, whatever.
Yeah, no, I think, again, the great thing is the answer is the same, such that you have to talk to the child's doctor, or you have to have some kind of communication between adult and child. You have to have the parents list their concerns or communicate their concerns in a way that can be heard. So if they're yelling and screaming, the child can't hear them. But if they don't list their concerns at all, the child won't understand. And then ask the child, the young adult now, how are you doing? What do you want? And then you start to problem solve and part together. But again, I think you definitely need a doctor involved because that's where the issue with ADHD becomes different. So yes, ADHD, a diagnosis in a young kid is pretty straightforward. And the problem, though, is as you get older, risk for depression sets in, risk for substance abuse sets in, risk for brain injury, risk, actually literally, head injury, concussion, risk for, other illnesses like, whatever illness you want to talk about that can affect the brain, whether it's thyroid, whether it's mono, whether it's whatever. And then, getting to, we haven't touched on the late stage of life because, life, we like kids, but if you think about actually to the other end of life as you get older, so, what's the difference between dementia and ADHD? The main difference actually is just the natural history of them. So with dementia, you start out being officially cognitively intact, and then gradually you're losing cognitive function. As opposed to with ADHD, you're born cognitively intact, but your brakes and your gas are just not the same developmentally.
It's so fascinating because they're just a leap all the way ahead. There are a couple of people here who said, I hope we can get to us baby boomers. And I'll just tee up a couple of those comments because they're really interesting. I mean, here's someone from Jerry who's 60. He says, I'm 66, and only in the last couple of years have I come to understand that ADHD is what I have struggled with most of my life.
Right.
I have a terrible time staying on task. What's my best option in terms of medication? And similarly, there's another person, I think in their 50s, who says, I was on ADHD medication, but I have developed hypertension.
Correct.
Is it more difficult to find medication for adults or people in their 50s and 60s that are effective? Or is it more complex?
Well, I think, again, I'm in full disclosure, I'm a child and adolescent psychiatrist, so I am board certified in psychiatry, and most of my practice. But I think that yes, it becomes more complex because you've got other health concerns to balance. You've got high blood pressure. So in kids, if their blood pressure is raised by a point or so with a stimulant, that's not a problem. There's no risk there because it's a non-issue. If you've got an adult with hypertension, different story. I mean, I think that's where you want to make sure that your psychiatrist and your internist, your psychiatrist and your cardiologist are communicating. And I think that's where, the number one answer is you got to go find a doctor that will take the time to listen, to understand things, to look carefully at the history. I think the history really tells the whole story. So, for example, the person who was saying they're 60 years old and they're just realizing now, if you look back, you probably can, if you have your old report cards. That's the best source of data. It's not the grades, it's the comments.
Right.
Go to your parents' house, if you can find it, get the comments from the old report cards, or find an adult that knew you when you were a kid, give them like a rating scale, and they'll tell you, you were like this, you weren't like this. And that's one piece of data, but then you got to go to see a doctor, and you got to sit with them, and they've got to be careful with you. They got to really understand, okay, yes, you're not focusing right now. It sounds like you've got a history of ADHD, but actually maybe, honestly, you sound depressed to me right now. You sound like, because when you're depressed, when you have major depressive disorder, you can't function, you can't think straight. It sounds like, your thyroid isn't working. It sounds like you've got eye problems. It sounds like you've got, being a doctor means that you really are careful. You really have to think of all the possibilities. And there is no substitute. There's no quick fix. There's no better way than to actually say, I've got this issue. Let me find my doctor. Let me see if they can help me. And whether it's actually sometimes starting with your primary care doctor makes the most sense. That actually, I think, especially for an adult, for an older person who's never been treated before, you want to get a good, clean bill of health. Make sure there's nothing else going on.
The questions here are so fascinating that I'm thinking we need a separate webinar just for
actually,
issues of people in their 50s and 60s.
Absolutely. And I think that you're right, because we have a whole life cycle, but again, I can spend years talking about the early years.
Right. And yet here we have all these adults who are now for the first time being diagnosed because diagnosis is so much more common in children that adults are saying, wait a second, that's me. And just the questions that are being posed here are fascinating. A husband who was hospitalized and for other issues, and the hospital wouldn't allow ADHD medication, so she had to bring it into the hospital. I mean, just lots of specific to the, issues of the 40s, 50s, and 60s, which, as we know, a huge baby boomer group out there. So, it's an interesting topic.
No, they're very safe medications. They're extraordinarily safe medications. Like any medication, they can be misused. And so there are laws governing stimulant medications. But again, Tylenol can be lethal in overdose. So every medication has to be respected. But these are extraordinary, when taken properly under supervision of a doctor, these medications are extraordinarily effective and safe. However, they have stigma to them. And I think that's, this kind of conversation really helps to understand what they are, what they aren't.
Dr. Dickstein, you've been really terrific. We're so thankful that you gave us this time, and hopefully we can have you back again, get another hour on your busy schedule, because your knowledge is really super.
Yeah, it's totally my pleasure. Thank you so much for having me, and I wish you all the best.
Thanks so much. Thanks, everyone. Bye now.
For more Attitude Podcast and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.